Okay, everyone, good afternoon. It is 3:01. We're going to go ahead and get started. We will be recording this. We are recording this and we'll have the recording to share afterwards. So if anyone joins late, you won't miss anything, but we want to make sure we get started and we have a lot to pack into a short amount of time. Again, this is Melissa Carolla with LAPCS. Many of you know me from the Bottom Line program. I'm also the Finance and Operations Director for LAPCS. I want to welcome our membership from across Louisiana. As everybody knows, these have been unprecedented times, and we want to be here every step of the way to support you. We've had a number of members who have reached out to various teammates on information on vaccine education and rollout plans for their teams. So we pulled pretty quickly together this town hall to help. We're really honored to have our partner, Children's Hospital Thrive Kids, here today to walk through this with us, through the history, medical guidance around the vaccines, logistics, and vaccine rollout, as well as answer many of the questions that some of you posed during the registration and some questions that they had gotten in general. So welcome. We hope this is informative. If you have any questions throughout that weren't submitted in advance, feel free to use the chat feature. We will be monitoring that and trying to get all those questions answered. So I'm going to go ahead and kick it back to Kimberly. And thank you all for being here to support our school communities.
Thank you, Melissa. Thank you for having us on. I'm sorry that was hesitant for a moment there with the technical glitch. Appreciate everybody taking some time out of their afternoon to join us today to spend some time talking about the vaccine and COVID-19. And we are grateful to have the partnership with the Louisiana Association of Public Charter Schools. My name is Kimberly Buckingham. I am the manager of our Thrive Kids Student Wellness Program, and I'll be our moderator today. Joining us from the Children's Hospital Thrive Kids side is Dr. Leron Finger. He is our Chief Quality Officer and has led our COVID-19 system response as a whole. So we're really grateful for his advice and insight for today. We also have Patricia Hewin. She's our school nurse care coordinator. She's an excellent resource to schools, and we always like to have her available with us as a good contact point. So we'll go ahead and just dive in real quick and get going on just a high-level reminder on resources that we have available for schools. And then I would like Dr. Finger to give us a quick briefing on some of our school decision tree guidance, and then we'll jump right into the COVID-19 vaccine discussion. Just a reminder, we do have a hotline that's available to all schools statewide. That's 504-837-7760. Option 1, after you call that hotline, you can have guidance to all COVID-19 medical guidance questions. We have a team of nurses that's operating that 7 days a week. You can also have virtual visits with a physician, return to school screening, enrollment in at-home symptom monitoring, as well as testing access for the greater New Orleans area. So we're really happy to have that team available. Additional to that COVID-19 medical guidance, we do have our video visit option that's 24/7 virtual care available for the pediatric community. So families have been really appreciative to have that resource if they have to pick somebody up sick from school. Also, I'll point out that our website is always available to schools. We've got our decision tree listed on there. We've got flyers for parents, signage at school. Every town hall that we have is posted on there as well so that you can share it with the rest of your staff. And we also have an FAQ submission opportunity. So feel free to check that out, as well as access our email inbox. That's thrivekids@lcmchealth.org. We have a team that looks at that every day, all day, and is there to answer your questions. So Dr. Finger, would you mind just getting started with giving us a debrief of what our school decision tree looks like? We'll start with a symptomatic individual and then go into the close contact one.
Sure, Kimberly. Thank you, and thank you for having us here today. In some ways, this feels so 2020 because vaccines are so 2021, but it still is important to understand how we screen individuals for our campuses who are symptomatic. This is sort of a compilation and an algorithm that I suspect many of you have seen on our website or the Department of Education website that really takes all of the recommendations from the CDC and our local Office of Public Health in the state of Louisiana and puts it on a simple 1 to 2 pager for how to approach folks who have symptoms that might be compatible with COVID-19. Obviously, if they are symptomatic on the campus, the first thing we do is figure out a way to get them off campus. Their choice is to either get evaluated by a healthcare provider, or if they're well appearing, they can just simply get a COVID test. If they do get evaluated by the healthcare provider, they are allowed to give an alternate diagnosis and determine that a COVID-19 test is not indicated, in which case that child or team member should stay home until their symptoms have improved and they've been fever-free for 24 hours. The healthcare provider might advise that individual to get a COVID test, at which point we go to the left side of the algorithm. The COVID test is obtained, and you can click on that link there to see what type of tests are recommended. If the test is positive, then that's an individual who needs to isolate, regardless of whether they're symptomatic or not. And they stay in isolation for at least a minimum of 10 days and symptom resolution, and they need to be fever-free for 24 hours. In addition, at that point, you would try and notify all close contacts with that positive individual. If their test is negative, then they simply stay home and until those symptoms are improved and they've been fever-free for 24 hours. Again, looking at that test in the middle, the text, T-E-X-T, if no test result or healthcare provider has been confirmed within 48 hours of the onset of symptoms, we recommend contacting your local regional medical director for advice. And based on local case prevalence and your description of the child or team member, they might decide to simply treat that person as a presumed positive patient if you don't have that answer. But that's something that only your local regional medical director's team can make. Next slide. This is our sort of screening approach for individuals who have been deemed close contact. And if we recall, close contact is an individual who's been within 6 feet of someone who has tested positive for COVID-19 for a cumulative total of 15 minutes or more over a single 24-hour period. And that exposure needs to have taken place within 2 days of the positive person's either onset of symptoms or positive test result, whichever came first. So if you guys, not necessarily the regional medical directors, are in charge at a local level of identifying those close contacts, and those individuals need a quarantine. So up until December, that was for a 14-day period minimum. In December, the CDC came out with new recommendations that gave options for decreasing the duration of quarantine. If you go down to that gray box in the middle, there's an option to get a test at day 5 to 7. And we really recommend that all close contacts who have the opportunity to get tested at day 5 to 7 after the exposure. If they do get that test and it's positive, you flip back to the symptomatic decision tree on the first page. If it's negative, there's the option based on local school rules to return to school after 7 days in quarantine. But that can only be done if that individual can maintain mask wearing and social distancing through day 14. If they don't get tested at day 5 to 7, there's the option to return to school after simply 10 days in quarantine. But again, similar to the day 7, they still have to maintain all non-pharmaceutical interventions, which include mask wearing and social distancing, until the full 14-day quarantine period has been completed. And again, there is still a risk that between day 7 and day 14 that close contact might come down with COVID-19. It's not completely zero. So you really need to be aware of those individuals developing symptoms. I will tell you, many schools have chosen not to utilize the 7-day option because it's very hard and challenging to operationalize and track down exactly what type of test an individual got between days 5 and 7, and have simply used the 10-day opportunity. For younger kids who are below the age of 5 or in a place where you're not wearing masks, you can't really use the 10-day option, because those would be kids who then have to wear a mask while they return to school and be in a class of other people who are not masked. It's not really an operationally effective. So younger kids in below the age of 5, or if you're in a place where they're not wearing masks in K through 2, really don't have that as an opportunity. Kimberly, I'll pause there. I don't have the chat open and see if there's any questions that have come up. I went through it relatively quickly because it's been really in place for a long time, but see if there's any questions from the audience.
Thank you, Dr. Finger. We haven't had any questions come in yet, and I appreciate you doing that quick primer. I think it's always helpful. And just so everybody knows, this continues to be available on our website. It's as current as December 17th. We update it as soon as we can if anything changes, and this is a resource that's always available to you. We can come back to it if we have any further questions. So I'm going to move on to just a true town hall style open Q&A. When we asked everyone to register, we did have a field that allowed you all to submit questions. And so we have a long list that we'd love to go through and just learn about the COVID-19 vaccine. What is it? What can you anticipate logistically on the school side? And just walk through what a lot of those questions were so that we're being responsive to you. If you have any more questions, please put them in the chat. We'll make sure to answer them. And if we don't get to them in our discussion today, we'll make sure to coordinate some follow-up. And just as another reminder, this will be recorded and posted on the Genola website. So I'm going to go ahead and remove this PowerPoint so that we can just open up the conversation. So Dr. Finger, could you just provide us an introductory overview of what vaccines are available to the public and how that works in response to defending whoever gets them against getting the coronavirus?
Sure. Right now, just broadly speaking, vaccine development for COVID-19 actually began in earnest well before we knew the novel coronavirus was even in the United States. Back in January, labs started working on this when we understood the genetic makeup of the novel coronavirus and really utilizing a technology that many in the media have called new, but it's been under development for the past 2 decades. And essentially is a framework to create a vaccine exponentially quicker than in the 1940s and 50s when our first vaccines became available. And essentially what it does is it uses something called, the 2 available now in the United States are made by the companies Pfizer and Moderna. What those vaccines do is they use something called messenger RNA to go into our body, go into cells, and make a protein that looks similar to the protein that sticks out of the novel coronavirus, which causes COVID-19. After they make our body make that protein, the messenger RNA disintegrates, and our body creates antibodies to that protein. It doesn't do anything. Nothing changes, nothing else changes in our RNA or our DNA, but now we have those antibodies floating around. So if we were to be exposed to the novel coronavirus, our immune system is primed to respond immediately and in real time. As the companies developed those vaccines, they were allowed to begin vaccine trials almost in real time with the knowledge that doing those in parallel as opposed to in sequence would hasten the development and approval of the vaccines. And they went through all the regulatory requirements to do so and didn't cut any corners in doing that. And in both instances, over 30 to 40,000 vaccine participants from around the world were enrolled. And both of them showed 95% efficacy, meaning if 100 people got the vaccine, 95 of them developed a sufficient immune response such that it would prevent them from getting COVID-19 if they were exposed to the novel coronavirus. Truly a remarkable achievement and more efficacious than the seasonal flu vaccine that we all take every single year. So really a modern medical miracle as far as I'm concerned that they could achieve that essentially in under 1 calendar year. As I've told many people on webinars and calls within the city of New Orleans and Office of Public Health, this is the first step to ending this pandemic. And I think the safety data on this and is really impressive. I only wish we could get it out to more people more quickly than we have been able to do so. So that's sort of my overview on it, Kimberly. And I suspect you'll have some more specific questions for me as we go through.
That was great. Thank you so much. I know that several individuals have asked questions around whether the development of the vaccine was rushed. So it's really comforting to hear that, that you feel that isn't the case. So could we review some of the impacts of the vaccine, what the difference between what are short-term side effects and potentially long-term side effects? There's a lot of concern.
Yeah, no, absolutely. The vaccine is not without short-term side effects. As anyone who's a grown-up knows, when we get fevers, it's sort of different from when our kids get fevers. We feel crummy. And not an insignificant number of individuals who get this vaccine do have, your body responds to the vaccine by revving up that immune response and making those antibodies in order to fight the protein that we've now introduced to you. That's normal. So not an insignificant, and both of these vaccines, the Pfizer and the Moderna, are given in 2 separate doses. The Pfizer separated by 21 days, the Moderna separated by 28 days. The systemic responses, or your body's response, seems to be more profound with the second dose, although there have been many people who feel somewhat ill even after the first dose. That's common and it's transient, mostly lasting somewhere from 12 to 36 hours, and then with complete resolution. So that might include some arm pain at the site of the injection. Some people get a low-grade fever or chills, some GI discomfort and muscle pain, and then it's gone. Again, that shows you that your immune response is working. So after 36 hours, everything is essentially resolved.
And how would you advise individuals that might have chronic conditions or even say an autoimmune disease to think about getting the vaccine?
So the way, and I've counseled not thousands, but probably hundreds of people on that exact question. There's almost no absolute contraindications or reasons not to get this vaccine. I think the only one where I would be cautious is if you've gotten the first dose and had a severe allergic reaction to this type of vaccine, not even to other vaccines necessarily. If you've got a chronic immune condition, or you've got cancer, or rheumatoid arthritis, or something that puts you at risk, it's all the more reason to get one of these vaccines, because I suspect you might be at higher risk for severe COVID than if you didn't have one of those conditions. So I've counseled those individuals to absolutely get this vaccine when they are in the appropriate tier and eligible to do so. If they have any other questions, they can speak to their primary doctor, primary care provider, or subspecialist, who I suspect will mirror my recommendations.
And we had a really good question come in around being around others who might have a chronic condition or something like an autoimmune disease. The question that came into the chat says that this individual has the opportunity to get the vaccine, but their son has an autoimmune disease. And so this person's worried about getting it because she's worried that her son might be at risk, his or her son might be at risk.
I would say if her son has an at-risk condition, it's all the more reason to get it, because by getting the vaccine, you're not only protecting yourself, you're helping to protect your family and the community at large by being one less person that can get COVID, that can develop symptomatic COVID-19.
And that actually brings up a really good question that we get a lot. And that's that when you get the vaccine, you're not getting the coronavirus, right? Like you can't give somebody else.
This is not a live or attenuated virus vaccine. This is something that's completely different. You're not getting the novel coronavirus injected into you.
And so you'd say that the biggest impact of getting the vaccine is significantly decreasing your own ability to get coronavirus. There might still be a possibility to transmit it though, correct? But it's not after you get the vaccine, you don't have a live coronavirus you could give to somebody else. So this individual that's worried about their son shouldn't have to.
Absolutely not.
Thank you. And then what do you recommend for educating others or peer conversations around sharing information around the vaccine and how to really be an advocate for sharing information about
I think we need to be transparent. I think with the arrival of the interweb in the last 2 decades, anyone can post any information and people tend to take it at gospel. And that's just unfortunate because I think it promotes disinformation, and it's not people are ill-intentioned. I think it's people certainly believe that, but the science is true. And I think just being transparent, but also not pressuring people, I think, into getting the vaccine if they truly are vaccine hesitant. I find that honest conversations and meeting people where they are to understand why they might be hesitant is a way to promote actual helping them get the vaccine as opposed to bullying them into getting the vaccine. I don't think that's a reasonable approach.
And Sharon, I just saw your question come through the chat, and I'm going to get to it in just a moment. But before we pivot off of this, Dr. Finger, could we come back a little bit to some side effects? There's a lot of concern around there being long-term infertility, or that breastfeeding mothers or pregnant women shouldn't take the vaccine, or that it could make something like asthma or diabetes or hypertension worse. Do you have any thoughts specifically around some of those
short
conditions?
answer is no, it doesn't affect any of those conditions adversely at all. I think the question about pregnancy merits a little bit more depth. Again, the interweb is great and also has its issues, and there's a lot on the internet about issues in pregnancy. None of it is sound, and actually, although in the initial studies there was no subgroup carved out to include specifically looking at pregnant women were included in both studies and had no ill effects out of proportion to the folks who did not get the vaccine, i.e. got the placebo. In fact, when we internally discussed whether or not we would make the vaccine available to our pregnant team members, we thought it would be unethical not to offer it to them, and have strongly recommended that they get it. The American College of Obstetrics and Gynecology has recommended that pregnant women get this vaccine as well.
Great, thank you. Now, can we go into the difference between getting the first dose and the second dose and what that period in between means?
Sure. Essentially, I think about it as sort of priming the immune system. So all the studies were done looking at the response after 2 doses, and specifically 2 weeks after the second dose. We do believe that getting a single dose confers some degree of immunity. Whether or not that's full immunity or not, meaning 95% of the people won't get COVID-19 if they're exposed to the virus, we don't actually know what that number is. But we do know that after 2 weeks after the second dose is when you see that maximal effectiveness. To answer your next question, we don't know how long that's going to last yet, right? We're in the early stages of this. We don't know if this is a sort of once in a lifetime vaccine, or once and you get a booster in 10 years, or if it will be something similar to influenza, where there's a seasonal dose of the COVID-19 vaccine. We just don't know that yet.
And moving on to our second question in the chat about this, I'm going to pull up our decision tree just for reference. Dr. Finger, the question centers around whether if someone has received the vaccine and gotten their second dose, would that person still have to quarantine if they were confirmed as a close contact?
At this point in time in the state of Louisiana, the answer is yes. I anticipate that with time that might evolve and change, but at this point in time, and I discussed with the Assistant Secretary of Health at Office of Public Health last week, right now we are still quarantining those individuals who have been vaccinated if they are indeed deemed to be a close contact. I suspect that with time that will change, but not quite yet.
And is there anything, is there any condition that would impact somebody's ability to get their vaccine? So what are the few situations where somebody should hold off to get their vaccine?
Great question. So if someone has an acute febrile illness where they're sick, they should not get it until that illness is resolved. If they have known COVID-19 and they're within their isolation period, they should not get it. If they have been defined as a close contact and they're within their 14-day quarantine window, they should not get it. The final thing is, if they were previously diagnosed with COVID-19 and they, as a part of that their treatment plan, they received a monoclonal antibody or serum treatment, they should not get it for 90 days from the date of that treatment, because those things can interfere with the vaccine revving up your immune system and developing antibodies. Again, that's going to be a very small number of people.
Okay, so if we're looking at these decision trees, if you're able to return to school with documentation per school policy, you're able to get a vaccine, correct?
That's
aside from the
now,
last example.
we do assume that having had COVID-19 does confer some degree of immunity, probably for up to 90 days. That being said, if vaccine is available in your community, you can still get it.
Great, thank you. Now, can we start talking about timelines? There's a question around How long do we think we'll have to wait until kids underneath the age 16 are able to get it?
Great.
But can we talk about timeline as a whole as well?
Yep, great question. And just to be clear, the Pfizer vaccine, you can give it to kids who are age 16 and 17. Moderna is only approved for 18 and above. The trial for both are undergoing now down to age 12. I cannot tell you when that approval is going to be given. I anticipate the study group won't need to be quite as large as the initial Pfizer and Moderna study groups, but I can't tell you exactly when that's going to be. I know we're enrolling kids down to age 12 here locally, and I anticipate that several weeks after those kids have gotten their second dose of vaccine, we'll be able to see the early results from their antibody production. I'm confident that it's going to be good and robust. There's no reason to think that kids who are teenagers won't have the same response as our adults have.
So can we talk about who's currently eligible and maybe why?
Sure. The CDC and sort of a group of people, the ACIP, tried to come up with a sequencing algorithm to promote equity and equality when there are not enough resources to give to 340 million people who live in the United States. That being said, there are national guidelines, but each state can interpret those guidelines and individualize them for our state. Our state's first tier folks to get vaccinated were frontline healthcare workers. And back the week of December 16th to 20th is when that rollout began. On New Year's Eve, the governor announced moving sort of to the next tier, which includes individuals over the age of 70, plus several subcategories, including people with end-stage kidney disease on dialysis, individuals who can be described as home health patients, plus their caregivers, plus ambulatory healthcare providers, which can be a term that's broadly interpreted. That's the tier that we're currently vaccinating, in addition to still frontline healthcare workers who are still eligible. Remember, you might be eligible, but if you decide to wait on getting the vaccine, that still means you can get it later on. It doesn't put you back at the end of the line.
So what's the name of our current tier?
I think, are we in tier 1B, I think, is what it is.
Great. And for schools, when we're talking about school staff, we're doing all school nurses, anybody above age 70, and all ambulatory healthcare personnel at schools.
Yeah, if you fit into that tier and you work at a school, you can get vaccinated, but just the general school team member is not eligible quite yet.
Do we have any concept on when they will, like teachers or anybody else at school staff that's below age 70 and is not a healthcare worker?
They will be in the next tier, and we do not know yet when the next tier will be announced.
Okay. And that direction comes from the governor, correct? That's not something that
I mean, it comes from the governor with input from the State Office of Public Health. That's correct.
Okay. And could we clarify what ambulatory providers means in a school setting? Is that social workers, counselors?
Speech therapists, occupational therapists. Many schools have paras who deal with, who are one-to-one with kids who have some degree of developmental disability. So we've included all of those. I think you can allow local leadership to try and define that, but be appropriate as you're trying to interpret that.
Okay, great, thank you. And it's possible that, moving forward, say you are a part of this essential tier to get vaccinated. If you have somebody in your household or a spouse that is not a part of that tier yet, you're going to have people getting vaccinated in your home at different times, right? Like you can't bring your spouse in with you.
Yep, almost certainly you will have people being vaccinated at different times unless everyone is in the last group together.
Okay, great, thank you. And then last question about eligibility. If you're a non-US citizen and say you have a green card or a visa, but you're employed by, say a school and you're an essential worker, you'll be able to get the vaccine as well, correct?
That is correct.
Okay, great. Thank you. Okay, so pivoting back over to the medical sides around the vaccine, this is a big question that's come up. Does a COVID-19 test, is that required before actually receiving it?
Absolutely not. And that was one of the big things that went into this. For a known infection, you should not get it, but we don't test everyone before they get the vaccine.
Okay, and then what happens after you get the vaccine? So your, opportunity to get COVID-19 significantly decreases, but you can still transmit it. So what does that mean around taking precautions and social distancing and wearing a mask and things like that?
Everything we're doing now, we're continuing to do it through the fall. That's what it means. We don't change our behavior patterns. We stay with our nuclear families. We wear masks when we go out in public. We socially distance and do all of those things. And the day after you get the vaccine and the day after you get the second dose of the vaccine, we continue to do all of those things.
Okay, and we had a really good question come up in the chat around how quickly can a school nurse right now expect to get access to a vaccine? We can answer that for our local community as well, but could you go into what that might look like regionally and how you advise schools to start approaching these kinds of questions?
Yeah, I think I'll take it from 35,000 feet, not from the greater metropolitan area in New Orleans. I think your local school leadership should be able to dialogue with local vaccine providers who might be hospitals, who might be pharmacies, who might be community healthcare providers to determine how to best get you signed up for the list. They're dealing with the same tier group that I just mentioned, which is people over the age of 70, and still have a shortage of vaccine in order to meet the demand in your local area. So there's a wait list no matter where you look. So I think work with your school leadership and to determine what the best mode to help get you on that list is. I can tell you here, that's what we're doing, is working with school leadership to provide us with names who meet the current criteria, and we will reach out to them in an attempt to get them scheduled as our vaccine supply continues to be regenerated.
So for any schools that are, around the greater metropolitan area in New Orleans, I'm going to put our Thrive Kids email address into the chat. Please feel free to reach out and we can answer that question for you locally. Otherwise, continue to have conversations with your school leadership about that. It was great, Dr. Finger. Thank you. We also have a lot of individuals that are concerned around having to do their own screening before they go to get a vaccine, like understanding what tier they fall into, what they might be at risk for. Can individuals that are getting vaccinated trust the healthcare professionals that are administering that to them to do that screening for them, or do they need to become educated beforehand?
What screening, Kimberly? I'm sorry, I didn't understand.
Meaning understanding if something is going to have an impact on you. Did you have an adverse reaction? Have you been? Have you had COVID-19 recently?
Yeah, I think the consent process at all vaccine providers should essentially look the same, and they should be asking those same questions.
And then if there's any concern around having an adverse reaction while getting the vaccine, you can trust that there's going to be an emergency healthcare professional nearby at those sites to be able to address those issues, right?
Absolutely.
Okay, great. So maybe we can talk about the difference between the two vaccines and what's available. So Pfizer versus Moderna, and if there's anything else that we can expect around that.
They have a slight difference in their messenger RNA, creates a slightly different shaped protein that mimics the coronavirus, and the Moderna vaccine is actually packaged in the vial slightly differently, so it doesn't need to be kept quite as cold. Otherwise, they're essentially, for the purposes of this discussion, almost exactly the same, but they're not interchangeable, meaning if you get the first dose as a Pfizer vaccine, you need to get the second dose as a Pfizer vaccine. Same for Moderna. There are some vaccines that are currently close to the end of being developed and approved that are single dose vaccines. They work slightly differently, but right now they're not yet available, so we don't need to talk about those quite yet.
Okay, thank you. And then Sharon asked a clarifying question, Dr. Finger. She said, did I hear Dr. Finger correctly? Did he say he thought we would be masking, social distancing, and physical distancing throughout the summer into next fall?
Sharon, you heard me correctly. I would love to be disproven and proven wrong. I can't see how we achieve herd immunity before the summer at the earliest. So yes, I think you heard me correctly. There are some people who think we'll be going longer than that. So, but certainly I think through the summer is not a uneducated guess.
That's helpful.
Sorry.
And what would you say about traveling and things like that? Or seeing friends?
You know, I think I got this a lot over the winter holidays. I think there's one, you know, every exposure you have outside of your nuclear household is an exposure that increases the risk. I think if it's a exposure to another family who has been truly limiting their exposures, the risk is probably low. If you're going to see family or friends where there's kids aged 16 to 28 in the household, I suspect your exposure risk will be higher, because anyone who has 16 to 28-year-olds on this call knows that those are challenging individuals to be able to control their behaviors when you're not actually looking at them. So I think keeping that in mind and knowing that this will be time limited should help guide your decisions.
Okay, so can we start to think about or talk about what vaccine distribution looks like actively for schools? I know that you mentioned that schools need to locally talk to their school leadership and look for local medical providers to partner with, but what about actual rollout of the vaccine? Do schools need to be prepared for anything operational?
Yeah, for the most part, I would say no. I saw a question come in asking, yes, I remember the H1N1 year as well. That question comes. This unlikely, because the need for the specific type of storage. I think we've not encouraged a lot of schools to become those vaccine providers because of the fragile nature of the vaccines and the entire rigmarole that is going out with this national and then statewide rollout. But I do think it would be important to partner with your local vaccine providers to see how to make it easy for your team members to get in the line once that your tier is eligible.
And schools don't need to make any investments in items like refrigerators for the vaccines or any equipment.
I can tell you, we have discouraged that locally in the greater metropolitan area, as the bulk of the vaccine providers are larger healthcare organizations, pharmacies, etc.
Okay, great. Now, as far as the efficacy of the vaccine, what's the, let me back up. What's the percentage of the population that we're hoping can get vaccinated in order to reach herd immunity?
So best guess is somewhere around 70 to 80%. There are certainly some scientists who think we might achieve some degree of herd immunity at lower national rates than that. And there's a small subset who think we actually need to be higher at 80 to 90%. But I think the sort of Gestalt average is somewhere around 70%.
Okay. And what do you think the likelihood is of a significant amount of the population getting their first dose and then never coming back for their second dose?
It's certainly a possibility. I will tell you, based on the eagerness of people to not want to get COVID, I think it's going to be lower than we might expect for other things where we rely on our on the people around us to do what they're supposed to do. It certainly will be somewhere, I suspect, in the 5 to 15% neighborhood, but I don't think that should negatively significantly impact the herd immunity goal of 70%.
Okay, thank you. What do you know about the vaccine's efficacy with the new strain that we're starting to see in the news?
Yeah, there's several new strains that have been identified. The sort of probably most famous one is B117 from Great Britain and South Africa. Our initial intel looks like the vaccine should still work against these variants. So I will say that, yes, they might be slightly more quote unquote contagious, but it looks like the end result of the vaccine is that it should still work because the makeup of the protein is similar enough that our antibody system, our antibody response will still be enough to attack it.
Okay, and what would happen if you weren't able to get your second dose of the vaccine within that recommended window? So you had to wait 4 weeks or 5 weeks.
You still get it. We think it should still promote, it just hasn't been studied, but we would still give it to you and you do not need to start over from the beginning.
Okay, so if you get the first dose and say you actually do come down with COVID-19.
Yep, and I've actually seen that. I've seen that a couple of times. Remember, because you could still have been exposed to COVID within 1 to 2 weeks before getting your dose and not known about it. So again, you wait until after your isolation period is over. before you can get your second dose. So depending on where you are in that day 1 to day 21 window might impact when you can get that second dose. You could also elect, if you wanted to wait until the 90-day mark had passed. I have recommended that people get it as soon as they're out of their isolation period.
Okay, great, thank you. And one last question medically, and we can transition over to some more logistics around the vaccine. Sure. Can you explain the difference in why there might be different perspectives on vaccines across different countries, like say between the United States and the UK, et cetera?
The authorization in each different country is owned by a different entity. So here we rely on the Federal Drug Agency, FDA, to approve those vaccines. And right now it's actually under an emergency use authorization. Every country has a sort of different way that those get vetted internally. They're mostly about-ish, the same-ish, but not exactly.
Perfect, thank you. Okay, so just going into the logistics around the vaccine, do you anticipate there ever being any high costs or out-of-pocket costs for patients that receive it?
There should not be. So many institutions are, if an individual has an insurance card, they'll take it just to bill the administration fee of giving the vaccine. The patient should not incur any copay for the vaccine. And folks who do not have insurance can still get the vaccine. And the bill for that is essentially being eaten by the federal government.
Great. And will there ever be a threshold as a community that we cross where this vaccine is actually required?
I think so. I think you guys who all work in schools know that there's a list of childhood vaccines that are required for entry, with some rare exceptions. I think we're a little bit early to talk about what that might look like, Kimberly.
Okay, but right now it's not actually required.
That's correct.
Okay, great. All right, so we talked about timeline, and that was really helpful. Would you recommend educators individually have extensive conversations with medical professionals about the risks of taking the vaccine or consulting their own doctors? Or do you think, information like on this webinar or reading online can be as helpful?
I think each person is different. Many of you might be meeting me for the first time. There's no reason for you guys to necessarily trust me. I understand that. I think do your own research and make your own decisions, but make sure it's an educated and well-informed decision from someone that you trust, that understands the science behind this would be the most important thing. But I think gather as much information as you need to make yourself comfortable.
So what happens whenever we hear new things in the news that might be confusing or pique our interest? What's the best way to go learn about the vaccine and kind of process that information so you can feel empowered?
I actually believe a single source is the CDC, that their website is actually relatively easy to understand. It's built for non-medical professionals. And although it might not be up to date every minute, it doesn't need to be up to date every minute. For major things that are change agents, it gets updated. And I think it's a nice section with a broad overview on vaccines.
Okay, thank you. All right, everyone, we're coming up on our last 15 minutes. I just want to encourage you to keep putting your questions into the chat so we can make sure to funnel those into our conversation. Otherwise, we're going to keep referencing questions that were pre-submitted as conversation points. So thanks for everyone that's already submitted questions. So if you've had COVID-19 and you get a vaccine, do you have any stronger immunity than anybody else? Or is that like triple or double your immunity in any way?
Say the question again. If you had COVID-19 and you got the vaccine, are you Superman?
Yes. Are you like a superhero?
I mean, you should still wear a mask, but you probably have a appropriate immune response to ward off any further COVID-19 in the next few months.
Okay, great. And do you anticipate parameters or guidance around school closures to change after the majority of a school staff gets vaccinated?
Probably too soon to tell, and I can't imagine that that is going to happen across the state and the country, in the next 2 months. So probably not, because remember, the vast majority of the kids will not have been vaccinated by that point in time.
Okay, and this is probably also a premature question, but when this vaccine does become available to children under age 16, do you have any thoughts around how logistically that will happen for schools? Will schools be responsible for administering that, or will it have to be on the families' responsibility?
Yeah, almost certainly the families will be responsible for helping to facilitate that. At that point in time, there might be local vaccine providers who are willing to come out to schools to offer those sort of vaccine clinics. Some of you guys might actually be involved with that with the seasonal flu vaccine, but probably too soon to talk about what that might look like.
Okay. And just as a reminder to everybody that's watching right now, this is actively being recorded right now, and it will also be available on our website afterwards. So we'll make sure to get with LAPCS and provide that link so it can be emailed out. So just to assuage any concerns around that. So Dr. Finger, do you have any other recommendations for school leadership that might be present on our webinar today on just how to start wrapping your mind around logistically coordinating this for your school? I know you mentioned earlier, find a community partner, but do you have any other thoughts?
It's never too early to sort of get your information and ducks in a row, which might mean taking an internal survey of all your team members. And remember, you've got team members who are educators, team members who work in the dietary department, who drive buses. Everyone's a team member. So meeting them where they are, taking a survey to gauge who would be interested in getting the vaccine, getting maybe some broad demographic information. So you've got that list so that when you do reach out to your local vaccine provider, you can say, hey, I've got 100 people who are eligible. What's the best way to help me get them signed up in total once they're eligible to do so? I also would strongly encourage people who meet current criteria to get their vaccine signed up now.
Great, thank you. And so if school leadership is collecting information from their staff members that are willing to get the vaccine, do they need to get things like social security number and insurance information, or can they just collect name, number, and make sure
I think what most vaccine providers now would need is sort of just to get general numbers for what they might be looking at, so you can engage with that dialogue at a very high level.
Okay, great. And we've had a couple of schools send over that information to us locally. That's been really helpful. We have had to remind schools to be mindful of sharing any sensitive information securely. So that's just something to keep in mind as well. Dr. Finger, what do you think about mobile sites? What's the likelihood of us getting to a point where we can have mobile vaccine distribution?
I think for the large part, most of these will be done at large single site centers where you have a large number of workers working and people just cycle through. As we get further down into the next several weeks and months, that might be an option, but remember the logistics of that are you're taking a team out of their local site. So we'll just have to see. I think the H1N1 couple of years that we had were slightly different because the storage of the flu vaccine is much easier than these current sort of super cold vaccines we have now. The other thing, Kimberly, is the availability of some of the vaccines that are in the final stages of development that are single dose will also be game changers and might change our delivery patterns as well.
Okay, that's helpful. Let's see, as far as pieces of the school's staff, population that might have hesitancy around getting the vaccine or have concerns around it, how would you encourage school leaders to continue to address those concerns? Should there be open town halls inside the school? Should they give them resources? What do you think?
Yeah, I think a combination of all of the above, but maybe with understanding the makeup and the composition of those team members, so you can meet those team members where they are. I can tell you what I've done personally at the hospital is I've personally gone to many of our non-clinical areas to speak to individuals, and the talk looked slightly different than this talk did. I answered questions. I could tell them I've gotten the vaccine. I've gone back after the second dose. I've gone back and talked to them about my mild side effects. And now that many team members have seen that I'm okay, literally it's that personal, they are now starting to sign up for the vaccine. So I think school leadership really can set the tone But it doesn't have to be, like I alluded to in the beginning of the conversation, in a professorial manner. And I suspect that most of the people on the call understand that sort of delicate balance that needs to be achieved.
And what do you think has been the biggest source of hesitation around maybe clinical staff members or non-clinical staff members here at the hospital?
So there's parts of the community who have a historic distrust of the modern medical establishment, and that's multicultural and multifactorial. We don't need to get into that history, but I think it's distrust just in general. The perception that this has been rushed and they don't believe it. There's a much smaller percentage who think that COVID doesn't exist. I think that's not what we're talking about now. So it's sort of like, I don't believe in the science is the major bringer. There are some folks, another small percentage, who don't believe in vaccines in general, but again, that's a much smaller percentage.
Okay, thank you. Denise submitted a question to the chat that says, does wearing a mask protect the person wearing it in terms of catching any viral load?
Yes, absolutely. Okay. The answer is yes, yes, yes.
Can the virus go through the mask? So
COVID-19, although there's a chance it can, it's not zero, it's exponentially decreased. So it's from going through the mask. And as you guys have also probably seen this year, we also don't have nearly as much flu and RSV in years past because it's protective from those viruses as well.
And so this is a really hard question. I know you don't have a crystal ball, but what do you think at this point in time the rest of 2021 could look like? And what should we be excited about?
I'm excited for Jazz Fest 2022. So, that's what I'm aiming for. I think 2021 fall has the potential to look a lot different than where we are right now. I don't think there's going to be massive existential environmental change in the next few months. I just think it would be unfair for me to let people think that we're not going to have masks on this March. I think that's just not likely. But I do think fall of 2021, we could be in a completely different place if our supply chain and our enthusiasm for the vaccine does not ebb over the next several months.
Thank you for answering such a hard question. As we finished up with our last few minutes here, do you have anything else that you want to say that you think would be helpful for this group to hear?
No, I hope this has been helpful. I thank you for all your hard work that you've done since last summer in keeping our kids educated, keeping our kids in school, and keeping our kids and your team safe. I know it's operationally, existentially challenging, but it's been a pleasure to be able to work with schools across the state of Louisiana, everyone working for a common goal. And for that, I really thank you for your efforts and hope you're excited about 2021. It's going to be a better year.
Thank you, Dr. Finger. Melissa, do you have any questions or anything you want to end on with our last 5 minutes?
Oh, I have so many questions. I just want to say thank you so much, Dr. Finger, for your time today and for your very candid and open responses. This was really helpful. I was just telling someone on my team, in all the webinars and all the trainings that we've done, I've literally never seen this many questions about anything. So I know that this was extremely helpful for our membership, and I'm sure that they'll have lots more questions coming up. I know we have a pretty direct line to our partners at Children's. Kimberly hears from us quite often, especially when we have urgent requests. So again, thank you everybody for taking the time today to join us. I hope this was helpful for everyone. Thank you again to our partners at Children's. And as we will continue, as more information comes out, to work with our partners at Children's to continue to bring you the most up-to-date and factual information. So I hope everyone has a great rest of their day. Thursday, I know it's 4 o'clock and folks are starting to shut down. And we look forward to talking with everybody soon. If you have any additional questions that we didn't get to today or that you'd like to share with us, feel free to email us at LAPCS and we will get those questions over to Children's.
Thanks, Melissa. Thanks, everyone. Please continue to use us as a resource. We have that Thrive Kids at lcmchealth.org email address. We also have our hotline, that's 504-837-7760. And we're working closely with Melissa, of course, and all of you. So thank you so much. Have a great afternoon, and we'll post this on our website as soon as we can.